The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with Inside JACC, and I'm talking to Dr. Luigi Biasucci. And Luigi is a good friend of JACC. He's been one of our best reviewers, and he's here in an interesting capacity as an editorialist for an important study that we're about to publish that deals with the risk of adverse events in patients with ST segment elevation MI, published by Dr. Damon and Associates. So, Luigi, tell us a little bit about the paper.
The paper is an interesting paper that explores the risk of death in about 1,000 patients, all with ST elevation MI. These patients were middle risk because the patients at higher risk, like patients with cardiogenic shock and those with rescue PCI, were not included. The mean age was 62, so not extremely high risk, but all comers were treated with primary PCA, and the peculiar point of the study is the analysis of biomarkers. They assessed NT-proBNP, the renal function, glomerular filtration rate, high sensitivity C-reactive protein, troponin T, the fourth generation, not the last one, and glucose level. And they assessed these biomarkers. And I think this is interesting because in the last years, we have not had a lot of interest in biomarkers and in prognostication in STEMI.
Yeah, well, and their particular approach was to determine whether multiple biomarkers, rather than one or more, could add to conventional risk factors. One of the things I think they did well was that they applied the risk factors such as age that we all know are operative, and then saw if there was a reclassification of using the multiple biomarkers. Now tell us, what did they find?
What they find, I think you're absolutely right, because one of the problems where you describe a new biomarkers, that it can be associated with risk, but what gives more than TIMI, age, or whatever. So what they did is to first assess the risk on the basis of the TIMI risk group, and then they reclassified the patient according to first the single biomarkers, and then the three biomarkers, glucose, BNP, and glomerular filtration rate, that were independent predictors. And what they found was that with this approach, they could improve the prognostication and separate the population in three groups: very low risk, less than 10% of death at 1 year; intermediate risk, about 15%; and very high risk, about 40% of risk at 1 year.
Yes, well, it's interesting because we tend to think in this era of PCI that if, in fact, you're in intermediate risk and you get PCI, you should do very well. But they showed that even within that group, with the very high-risk patients removed, there was still a considerable risk, at least utilizing those three biomarkers. But, you know, my head is spinning. Every day I'm reading about a new risk factor for STEMI or for non-STEMI. And how do you put that together? How many of these markers do you use really when you treat patients?
Well, I think that we use glomerular filtration rate and glucose because we know that they are extremely important. We use for prognostication, and of course, we can treat the patient differently according to glucose level and, of course, also the glomerular filtration rate. BNP is useful for prognosis, but we don't use very much for treating the subject. My opinion is that they really fine with these old biomarkers, if you want, because the new one, like metalloproteases or others, have never really been shown to be useful. What they found was a very sick population that probably was not able to survive to the infarction. They had diabetes, or in any case, high glucose. They had, with high BNP, they had a left ventricular function that was poor, and they also have the renal function, which was reduced. And we know that patients with these characteristics have a worse coronary artery disease, lower ejection fraction, and higher risk.
And I guess the last point, of course, is what more to do. These are patients who are being optimally treated, who've already undergone PCI. We probably don't have many alternatives in these patients.
I agree with you. The authors suggest the possibility to better treat in the early phase because the mortality was confined in the first month. So to better treat these patients, but they were treated state-of-the-art in a large hospital in Amsterdam. So I think they got everything that was possible. And I don't think it is reasonable to take shortcut to give, for example, more aggressive antithrombotic treatment to patients just because they have renal dysfunction. Of course, this may turn the other way out in a worse outcome because of bleeding. So I think this is useful, but we have to really realize what is really useful for the patient, and not necessarily this is the way to find it.
Yes, well, perhaps more rigorous control of glucose, maybe watching the diuretics a bit, as you suggest, with glomerular filtration rate. But again, perhaps most valuable in risk stratifying patients for future interventions so that we can assess their efficacy, but perhaps not something for day in, day out treatment. Thanks very much for being with us. For Inside JACC, I'm Tony DeMaria.